morning. Thank you very much. I'm honored to present this talk. My thanks to Dr. Allen, to Ara, and the club for the invitation. So my charge today is to discuss the localization of pulmonary nodules, particularly directed to surgical resection, and then part B is going to be to speak a bit about the ablation of pulmonary nodules that are not suited to surgical resection. I have no disclosures that are relevant to this particular talk. So even in the last decade or so, there's been a significant paradigm change in the management of pulmonary nodules. The nodules that we see now are smaller. They're usually sub-centimeter in size. They're of indeterminate biologic activity. Most of the patients are asymptomatic. The nodules are benign. And the lung cancers that we're seeing are a smaller and earlier stage. So the impetus for sublobar resection is there, and the need now to localize some of these smaller nodules is increasing. I think we all agree that the management of these nodules is best done under the auspices of a comprehensive thoracic oncology program or a thoracic program. The key components of this are a screening program, a multidisciplinary lung nodule clinic. There must be technology for the early detection of these nodules as well as for staging of a known cancer. Navigation is important, and then all therapeutic modalities should be available to deal with what's found. So this slide basically illustrates some of the nodules that need to be localized if you're going to be performing a sublobar resection. So it's either a ground glass nodule that you see or a very, very small peripheral nodule, a mixed density nodule that's somewhat deeper, a small centrally located nodule that's in a location that's difficult to palpate, and a PET positive small lesion. So I think we would all agree that these nodules would be aided by localization. So at VATS, generally, we're able to identify nodules which are about 5 millimeters or so in a subpleural location. Anything deeper is really hard to see from the surface, and you really need to be able to palpate a deeper lesion. And then non-solid nodules are just difficult to palpate. So in general, the nodules that need to be localized are nodules that are difficult to see or to palpate. A nodule that is in a location that's difficult to palpate. Small, deep nodules, a nodule that's less than 1 centimeter in size or more than 5 millimeters deep. A nodule where obtaining a margin on it is of concern, and in a hostile operative environment such as a redo situation or a prior irradiated chest. I'm going to divide this into preoperative localization and then operative localization, which is still mostly investigational. In terms of the preoperative localization techniques, there are really two big categories: CT guided or CT based techniques, and then bronchoscopic techniques. So I'll talk a bit about CT guided Koi localization, and this slide shows some of our data where it's really possible to localize small nodules in all 4 lobes. So on the left-hand side, you see an upper and a lower lobe small nodule being localized, and on the right side, a left upper and lower. So pretty much you can get to most nodules in most in most lobes. The one area where CT guided localization might be difficult is by the diaphragm. Some recent papers and articles on the success of CT guided microcoil localization. So Richard Finley is going to present his abstract next month at AATS. A small group of patients, but this is the only prospective randomized trial looking at coil localization versus non-localized patients. There is significant success with localization versus non-localization, significantly decreased operative time, and fewer use of staples, all things that we would expect. The Emory group just published their series of about 60 patients last year in Annals. Excellent results, a 98% success rate with localization. The nodules were all very small, so less than a centimeter, and fairly deep, up to about 19 millimeters. And a very low rate of complications, just 3 being migration, embolization, and a hematoma formation. We've been interested in this for the last few years, and we utilize this with our robotic platform and use the picture-in-picture technology, which is spliced into the robotic console, and we approach this with an initial wedge resection and then move on to definitive therapy based on the case. So either go on to lobectomy or to segment, or with implantation of brachytherapy seeds. So it really gives you the full versatility of options in the operating room. So in general, CT guided coil localization provides a fast, practical, preoperative approach to localizing small nodules, particularly geared towards minimally invasive resection. The complications, as I said, are small in number, but the important ones are dislodgement of the coil. This particularly will occur if the nodule is close to a fissure. Bleeding and pneumothorax rates are fairly small, and there's that rare case of embolization of a coil. So the other preoperative techniques involve bronchoscopic techniques for localization. I'll talk a bit about the use of radial EBUS here. So meta-analysis of 7 studies using radial EBUS for localization of nodules showed a pooled sensitivity of about 71% for lesions less than 2.5 centimeters in size, and a prospective randomized trial comparing radial EBUS to CT has similar diagnostic accuracy, but as we would expect, complication rates are lower. So endoscopic techniques of localization generally have a lower complication rates than percutaneous techniques. I'll spend a bit of time talking about the growing role of navigational bronchoscopy. This is a fairly new bronchoscopic technique, and it uses technology that's similar to our car GPS system. The potential applications of this are broad. They include biopsies of small nodules, the placement of dyes and fiducials, and I think importantly a role or a future role in catheter-based endoscopic therapy of nodules. There are 2 main companies involved here, Super Dimensions, which is now Medtronic, and Varen Medical, who are here today. Some of the advantages I see of the Varen system, so it allows real-time continuous tracking of the working channel as well as track tip instruments, so you know pretty much most times exactly where the nodule is. So it's real-time biopsy, real-time feedback, and guidance. The other advantage is that it does also offer a percutaneous platform for biopsy, and this slide shows the percutaneous application of this. It's a very straightforward technique. It can be done in the operating room, and it uses navigational techniques to identify a nodule percutaneously. You can place fiducials. Takes about 5 to 8 minutes to do this. A very straightforward technique. So in summary, navigational bronchoscopy is a growing tool for both diagnosis as well as for fiducial placement. There are 2 types of errors that I think we need to understand that do accompany the navigational bronchoscopic system, and you've got what's called registration error. So this is error that's related to matching the image fiducial space with the patient space. In the Verron system, it's about 2.6 millimeters. The other error that we need to know about is the navigational error. So this is the overall system accuracy, and it's fairly small. It's in terms of millimeters for the most part, but it takes account of myriad of factors, including the quality of the CT, the manual registration points. So it gives you an overall accuracy number, and you need to know what these numbers are. I think there's real advantage in tracking of your catheter as well as your instruments. It gives you more accurate results. The technology is expensive. However, in the appropriate setting, the business plan makes sense, and I'll discuss that a bit later. I think the percutaneous applications are an adjunct and can be important, and there is a significant future for possible catheter-based therapies using navigational bronchoscopy. I'll move on to some intraoperative techniques for localization of pulmonary nodules, and these are still investigational, but I think with growing potential. So I'll talk a bit about my friend and colleague Sunil's work. This is using near-infrared imaging to try and identify pulmonary nodules. His work was published last year, I believe, in Annals. So it was a very preliminary pilot project, looked at 18 patients. So ICG-9, which is the contrast used for infrared imaging, was injected 24 hours prior. All patients had a thoracotomy done. The tumor sizes ranged from 8 millimeters up to 11 centimeters. So again, this was just a pilot feasibility study, and they were able intraoperatively to scan the surface of the lung and identify 16 out of the 18 nodules. The limitation of this technique, as they surmised, was the depth of the nodule. So any lesion deeper than 1.3 centimeters was not easily accessible by the scanning technique. There are some other investigational, fairly novel targeting agents. One, for instance, looks at the folate receptor, the folate alpha receptor that's found in adenocarcinoma. So if you can target that and then you can scan the surface of the lung, you should be able to find the nodule. Yolanda Colson has done some very nice work over the years where she's used ICG-9 again, mostly for intrathoracic sentinel lymph node mapping, and I think that may have some potential as well. Dr. Bueno presented his very nice experimental work with IVATS last year, and this incorporates intraoperative CT with surgical resection. So a lot of work being done in the intraoperative area, still fairly investigational at this time. I'll switch now to talk briefly about some alternative techniques to surgical resection for pulmonary nodules. So just to reiterate again to this group, for now at least, surgery remains the standard of care for the treatment of early stage lung cancer. When surgery is not an option, or in selected high-risk patients, ablative or non-resectional techniques can be utilized. Some of the options include RFA, microwave, cryo, laser, electroporation, and SBRT. And I'll talk very briefly about each of these with a bit of focus on SBRT. So the RF technique has been used for a long while. I think most of us have either seen it or have it available in our centers. Fairly straightforward technique. It involves the generation of an electrical current between an electrode that's placed in the tumor and a grounding pad that's placed on the patient. The results over the last few decades have been fairly uniform. So the local failure rate for tumors that are less than 2 centimeters is about 30%. the local failure rate for larger tumors is higher and up to about 80% for large tumors. There is a reasonable morbidity and some mortality with this. The major morbidity really with all percutaneous techniques is the risk of a large pneumothorax that needs a chest tube placement and a small risk of hemoptysis. Okay, the microwave is a technique that's receiving some increasing interest, somewhat different to RF, and it uses EM or electromagnetic radiation to ablate nodules. So heat is generated, but there is no current. It is a uniform heating technique. There is less heat sink effects. It can be used for central lesions. There is no grounding pad involved, as I said, and there's no interference with pacemakers. The laser technique has been used as well. The results are fairly similar to RF. The heat of choice for the most part is YAG, but other laser sources can be used. The local recurrence rate, as I said, as you would expect, would be fairly similar to RF and to micro, with a failure rate of about 30% locally for smaller tumors, and again, the same risks of pneumothorax, etc. I'll talk a bit about cryo because this is an increasing an interesting technology. It's different from the heat-based therapies in that the freeze-thaw technique does preserve the collagen matrix and the local architecture of tissue. So somewhat unique from the other ablative techniques. Because of that, it is a fairly safe option for centrally located tumors. It's being used increasingly now endoscopically as well, and CSA Medical is here if you want to meet with them. The zone of ablation is very clear when you're doing it operatively. It's rapid. It can be used for large tumors, and it does provide an analgesic effect as well because of the freezing. So I see an increasing use of this, and there's certainly an increasing use within the airway. A novel technique is electroporation, and this involves the delivery of an electrical current directly into the cell, the goal being to disrupt the cellular membrane, which then induces apoptosis. And again, theoretically, it's well suited to centrally located tumors and to lesions close to the hilum, etc., mediastinum blood vessels. So fairly experimental at this time, been used by Dr. Bilfinger. I saw his name here, so maybe he's around. We might be hearing more about this in the future. So in summary, in terms of image-guided techniques of pulmonary nodules, the local rates of control are less than SBRT. The local control rates are fairly good for tumors less than 2 centimeters in size. There is a finite morbidity with these percutaneous techniques. Microwave and cryo may be getting some increased traction in the future. And to my mind, these therapies are perhaps best suited for failed in-field recurrence after SBRT in this current era. So SBRT is basically a technique that delivers high-dose radiation in multiple fractions using beams and coarcs to a tumor target. SBRT requires very precise definition of the target. You need to account for respiratory motion with respiratory gating of some sort. The planning target volume is tight, and you need some daily setup changes as you deliver treatment. It's delivered in 3 to 5 fractions, and each fraction is about 10 to 20 grays. The data on SBRT is out. So short-term data initially by Timmerman in JAMA in 2010 showed that the local control rate was 55% at 3 years with low treatment-related complications and with high rates of tumor control. The mature data is now out. So again, this is presented at ASTRO in September. The paper is still pending. 55 patients, most of them stage 1, a few T1, I should say, a few T2 tumors. The median follow-up is now out to 4 years. The local recurrence rate at the site of treatment is very low. So 7% now at 4 years. The local regional recurrence rate higher, so this is within the lobe itself, 38% at 5 years. The overall 5-year survival, fairly good for this high-risk group of patients at 40%. So we do have some competition in this area. So I'll quote Jim Lukatich a bit from his talk last year. So how does a thoracic surgeon get started with ablative and with novel therapies? Well, come to meetings such as this and meet with surgeons and other technology leaders. You should visit a thoracic surgeon who has this all worked out and set up. I think that's absolutely critical. You should partner with interventional radiology if they're doing this at your center. Talk to the neurosurgeons and see if you can get a CT scan in your OR. I think this is going to be an evolving area. And then work with radiation oncology and do not give up the SBRT cases. And I'll talk a bit about this. So there is a separate CPT code now for SBRT. It's 32701. It's really dedicated to thoracic surgeons, and it involves the contouring, the planning, and the fractionation of radiation. It does provide you with 4 RVUs, and you can compare that with the RVUs for some of the other procedures. So for fiducial placement, bronchoscopically, again, it's the same. For percutaneous, actually slightly low. I'm not sure why. And then you can compare that to a lobectomy and a wedge. So it does provide about a third of the RVUs to a wedge resection. The radiologists have their own separate CPT codes, which are the 77 codes. So the thoracic code is 32701. So please make a note of that, and please do use it. So to summarize, microcoils are an effective, safe, and efficient way to preoperatively localize a nodule that's planned for resection. The coils can even be placed several days in advance, and we do this all the time. ENB, or navigational bronchoscopy, is going to have an increasing role in thoracic surgery, both for diagnosis as well as for fiducial placement. And I think importantly in the future, for catheter-based therapies for lung cancer, I think it's critical to collaborate with IR and with radiation oncology. Do not give up the SBRT cases for patients that come to you. Sit down, work with IR, and make sure you build your own code. And I predict that in the future, surgical platforms will have some innovative imaging techniques incorporated that will allow a 3D virtual roadmap for the important structures to aid in surgical resection. And with that, I thank you and remind you that the New York General Thoracic Surgery Club has its meeting next month on the 23rd. So all of you in the Northeast, please attend. And even if you're down south, we'd love to have you.